I don't think we can. He's a pioneer, one of the finest cardiologists, not only in India, internationally recognized as well. He is humility personified as well. You call him anytime and respond to you. And I remember at least one case. He's such a brave cardiologist. One of my patients, 25 years back, was admitted at Fortis. One of the leading cardiac surgeons said, we'll do a bypass. He had a multivessel disease. Dr. Kler said, you have an option of going for angioplasty. We can do that. And the patient, his name is Ramandeep, and he consulted me. I said, go ahead. If Dr. Kler can do that, and he's the ultimate man to do it, go ahead. He did that, and patient had a native coronary artery disease, had a genetic disposition as well. 12 years later, he developed again a stenosis. Dr. Kler again did angioplasty here, and 25 years now he's doing so well. So that's what Dr. Kler is today. Wonderful, sir. Like to say something?
Sir, nothing great. I'm reminded of Bhishma Pitama in Mahabharata. He's like that. हर तरीके से वैसे ही हो सर. वाल्मीकि हमारे मतलब जैसे उनके थे. So you are our old friend, not by age, but otherwise we know you for quite some time, sir. Ever since you were in Fortis, that escorts. So you are our inspiration, and we love to hear from you what is new in cardiology and especially electrophysiology, which is your forte. Sir, enlighten us. Thank you so much. मैं सिर्फ एक लाइन और कह दूं, राजस्थान में वो कठपुतली का खेल खेलते हैं, तो वो जो कठपुतली वाला जैसे नचाता है वैसे कठपुतली नाचती है, आप भी हार्ट को कुछ वैसे ही कर देते हो. Thank you so much.
Let's listen to him.
Am I audible?
Yes.
So, first of all, thank you very much, Dr. Verma, Dr. Tulsi, Dr. Kalra. You are all old friends. Old doesn't mean that by age, old means that we are from since a long time.
Old is gold.
Yeah, old is gold. And I think practically I know everybody. And I spent 28 years at Escort Heart Institute. And I still consider that's my hospital.
Wow.
So I worked in South Delhi. Most of the time my soul is still in South Delhi. So some or the other I work in Cmes. Cmes is a good hospital, multi-specialty, good staff, good capability. Little too much crowded, of course. And but fortunately we have every specialty what you can count in the world. Everything is being done there in that place. Coming to the cardiology, fortunately we have a very good team covering interventional cardiology, cardiac electrophysiology, structural heart disease. What we have done, what I have done always is that we create verticals in cardiology, vertical in interventional cardiology. Somebody specialized in structural heart disease like Dr. Malhotra, and he also does heart failure. Dr. Avinash is a dedicated electrophysiologist. I have another electrophysiologist, Dr. Verma with me. And of course we have a very good capable surgeon, Dr. Avinash, who was at the Scott Heart Institute, and he is with me. We have other people in the departments, Vash Chandra and Dr. Bhalla, Dr. Sabri. They are all good people. So I thought today that I show some cases to you, and then we discuss those cases. So this is a the type of cases we get very used to in the Scott Heart Institute when we started initially. Most of the time they were simple cases. Relatively people used to be young at that time. Gradually what has happened is the longevity of life has increased. So when the longevity has increased, the complex coronary cases have also increased. because some of the other people don't die now easily because you people are there to save them. So people have bypass surgery, then they develop graft occlusion, increase again more calcium, more toxicity. So we have different kind of very difficult cases. This is one of the cases I would like to share. This was 80 years guy. He had been having angina. Many years back he had a LED stent which was okay, and he had a right coronary artery occlusion. It was very calcified. Somewhere in Chandigarh, 2 times somebody attempted, but the balloon couldn't go through. Even 1.25 millimeter balloon could go through. So let me show you if I can share. While we are not moving away. Yeah, okay. So this was a look at the whole vessel is very calcified and it has toxicity, and even the BMW wire was not going, but some of the other I could pass the rota wire, and we did the rota ablation of this patient. Hopefully you will see that we have the rota wires, and look at it. Say even the origin is pretty awkward. That's the rota wire 1.2 word. Without rota ablation, no balloon will go in this patient. It's absolutely not possible. And still there was a lot of calcium, so in this patient I have to do even the intravascular lithotripsy. You must have heard, for dealing with the calcium there are 3-4 technologies. One is the rota ablation. If it's a very tight lesion, even the balloon cannot cross, then rota ablation is the best. That's the, because no IVL balloon will not go into those patients because it's a rather big profile balloon. IVL is used when you can dilate the lesion with 2 millimeter balloon or 2.25 millimeter balloon. There is a calcium all around, but you need some space to go with the IVL balloon. You cannot do lithotripsy unless you have balloon going into the lesion. So many times you have to combine these synergies. Like in this patient, we have to do rota first, then we did the IVL. After IVL only, we could pass a stent in this patient. You can see the stent going here, and then final result, which was very gratifying in this patient. Otherwise, you can't do this case. So, 23 millimeter Ablation Pro was done in this patient. Now, sorry, this is another case. You see a lot of this. What happened? Yeah. You see. It's not coming here.
Time left.
2 minutes.
वहाँ चलेगी
स्टार्ट हो शायद आ जाएगा
लाइट की वजह से
हाँ लाइट से उड़ गई
क्या मतलब
इसके साथ की लाइट है शायद इससे कनेक्टेड है उसे ऑन करवाओ
लाइट ऑन करवाते हैं
नहीं सर वो हो जाएगा
कैसे हो जाएगा
यूपीएस पे सर वो
अच्छा यूपीएस पे हाँ कर दिया
हाँ हो गया बस एक बार स्टार्ट हो गया
आ गया अच्छा यूपीएस पे आ गया
Sorry, till these lights come, so I will like to tell you that this is another case that for calcium, so there are 3 technologies. One is rota ablation. To my mind, it is the most effective. There is nothing worse rota ablation works. IVL is a good technology, provided you can go to you can pass the balloon to that place, then it's very good. The advantage of lithotripsy is that it is user friendly. Anybody can use. But for rota ablation, you need skill, you need experience. Even after many years of angioplasty, many people will not be able to do rota ablation. It needs more skills. The third technology which you may have heard is called orbital atherectomy. Orbital atherectomy is also something like rota ablation, but the bulb also does orbiting. So for that, you have only one bulb. You don't have to upgrade. But from the first trial which was done recently, orbital atherectomy has not done very well. So I really don't think that you should know for the time being. Of course, whenever we do these cases, you usually do the imaging in these patients. Either you do IVUS or OCT, and many times you can't do the imaging before you have done something to the vessel, because even the OCT wire will not go. But after the procedure, it is a good idea to always see that your stent is okay, you don't have dissection, the expansion of the stent is good or not. So that's the thing. Now I go to another, technology which is, you must have heard that there is a lot of development in structural heart disease. Previously we always used to do surgery for aortic valve, mitral valve, but now lot of treatments are coming which are catheter based, and one of them is the aortic valve. This is a patient who is 71, a very tight aortic stenosis, ejection fraction was normal sinus rhythm. You can see the significant gradient in this patient, and aortic valve is just 0.9. But this was bicuspid aortic valve. Bicuspid aortic valves are usually congenital bicuspid. Bicuspid valves are more prone to get stenosis as well as aortic regurgitation, and they are a little bit more difficult to do as far as the TAV is concerned. Many of these patients, they have additional aortopathy. Aortopathy means that there is a weakness in the muscle of the aorta, so they can get dilatation, they can form aneurysm. Some of those patients may need ultimately Bengals procedure, but anyway, in this patient aorta was not that badly. So when we want to do TAVR means the transaortic valve replacement, you have to do a CT CT aortography, which is very important because CT will tell you exactly the orifice size, where are the osteo of the coronary arteries, and it will also guide you which valve you have to select. There are basically two kinds of valves available. One are self-expanding valves. So you go to the aortic position where you want to deploy the valve, and there is a sheet over that. You withdraw the sheet, the valve will expand automatically. Another are balloon expandable valves. They are mounted on a balloon, and then you just expand the balloon, and there are advantages and disadvantages of both these valves, but you have to particularly select a valve which is particular to that patient. For example, the balloon inflatable, balloon expandable valve, the height is less. So if the coronary ostia are a little bit low, it is relatively safe in those patients. But if your annular size is small, if the annulus is small, like for example, many of these patients I have seen, we used to send them to bypass surgery, and if the annulus is small, then the surgeon used to put a 19 millimeter valve, either the same tube or a bypass valve. For 19 millimeter, you will always have a gradient, 30-40 gradient in the beginning. So these valves degenerate very fast. So now we have a technology which we call it supraannular. That means the valve is not implanted, the leaflets are not at the annulus, the leaflets are above the annulus. Supraannular means annulus is small, but above the annulus, supraannular area is wide. So the valve expands and the valve is there. So this is one of the valves which I will show you. So these are the kind of measurements. Not only that you need how much is the calcification, how many cusps are there, what kind of cusp confusion is there, how much is the calcification. Then you need to know the ostia of the coronary height. Because one of the complications which can occur in your TAVR is that if you occlude the coronary artery, particularly left main, you will have death on the table right away. So we have to see before procedure that coronary cornea and the coronary arteries are protected. So those are the measurements we always say, but if the coronary height is more than 10-11 millimeters, then we are relatively safe. Not only coronary height, we also see the sinuses. If sinuses are broad, then it is more safe. If sinuses are narrow, it is less safe. So all those things we have to teach. We also need to know the femoral, because most of the time we want to go for femoral route. What is the size of the femoral artery, external iliac artery, how much is the toxicity, how to go through those devices, the device has to go through that. So all the measurements are there. External iliac artery and the common iliac artery and the aorta. So they will tell you how much is the the diameter of those vessels. So ultimately in this patient we selected unit 29 FX and this is the procedure. It's pretty simple procedure that what you do is you first take a picture of the femoral artery. Right. Then you do the aortogram. So the aortogram will tell you the anatomy, and you always put a temporary pacemaker in these patients because when you want to deploy, you pace them at a high rate so that the blood pressure becomes 30-40. Otherwise, the valve will pop out. Otherwise, the injection of the contraction of the left ventricle, that will be pushed onto the aorta. So that is why this patient has a temporary wire. Okay, then you pass a wire through the aortic valve. The wire has crossed through the aortic valve, and this is just to see the valve. We check the mounting of the valve that it is proper or not. After the valve has gone, then you want to dilate the valve with some balloon. Right, so this is the balloon dilatation. Some of the patients we don't do pre-dilatation, but if you say bicuspid aortic valve, then most of the time it is recommended that you do the dilatation in these patients. Then the valve is going. You can see the valve going on the right side. That's the valve which is in the sheath. That's the Medtronic evolute valve. And if you see that we are having difficulty in entering the left ventricle because it is like more horizontal aorta. But then there are some maneuvers which you take a deep breath, or sometimes we have to put an additional wire to guide entry into the left ventricle outflow tract. So ultimately you are able to send the valve to the valve has now gone into the outflow tract. Then you start releasing the valve. So you pace them and you start remove the sheath gradually, and now the valve is opened on the right side, on the lower portion. It is still not totally deployed. So at this time we see the functionality of the valve, see that everything is okay. Once we are satisfied, then you can release the valve completely. Like it is still not released on the left side, you see, and on the right side you see the valve is totally released, and you do the aortogram to see there was not much of aortic regurgitation. So you see after the procedure that kidneys are flowing well, how much is the aortic regurgitation. Of course, we always use echo during procedure because more than mild we don't want to accept the aortic regurgitation. Mild is acceptable in these patients. Right. So after the procedure, mean gradient was 5, paravalvular leak was 0, ejection fraction volume was 45%, and fortunately no vascular complication and no conduction abnormality. Almost around 3 to 5% of patients when we do the TAVR, they will do a complete heart block. Why? Because the conduction system from the sinus node to the AV node is very close to the aortic valve. So that is the place where there is a hip bundle and the left bundle. So even during surgery, for example, patient going for surgery in the aortic valve, around 3, 4 or 5% or 6% in many cities, they will develop complete heart block because the conduction system is damaged during the procedure. So that is why we also keep the temporary wire, and some of those patients, if they develop a complete heart block, then they need a permanent pacemaker, but this patient was okay. So in conclusion, this was a successful treatment of bicuspid type 1 valve with no complication. Post-treatment patient has done well, and we followed in the OTG. Now I will change the gear to show another case. So this was a patient, shifted from Mizoram. He was having bad heart failure. Actually, ejection fraction 35% was later on, but when he came, it looked like 50 to 20% because he was continuously tachycardia, and many times the tachycardia, this is the type of tachycardia you see, I don't know how many people will be able to tell me exactly what is this. This is a narrow complex tachycardia. Anyway, to save time, I just want to say that when you see ECG, it looks like a regular. Don't immediately jump that is a regular tachycardia. See carefully, see RR interval. So in this patient, if you see RR interval, you will see a lot of variation. That means it's atrial fibrillation. It is not a supraventricular tachycardia of like AV nodal related tachycardia or based on any accessory pathway. This patient was having a fast ventricular response, and many times actually I don't have the ECG. Many times it will be broad complex. So even we were debating initially that it is ventricular tachycardia. But remember, when patient has a supraventricular atrial fibrillation with fast ventricular response, you can develop broad complex because of the ablation. Now I want to know from anybody what is ablation.
Accessory pathway.
What is ablation?
Ablation is away from normal.
See, for example, let me rephrase. This patient used to have narrow complex tachycardia, which may he will have broad complex. Irregular. So, if it is a broad complex tachycardia, there are two possibilities. Either it is a VT, ventricular tachycardia, or it is some kind of supraventricular rhythm.
You can distinguish
Either with ablation or with pre-existing Vanderbilt block. For this patient didn't have pre-existing Vanderbilt block. So, what is the meaning of ablation? You must have heard that there is the broad complex tachycardia because of ablation. No.
Sir, SVT would be a narrow complex
Right.
as compared to a ventricular tachycardia would be a broad.
Right. But you can have supraventricular rhythms which have a broad complex.
Yes.
And what are those? Tell me, Tulsi.
We learn from you. Yeah. We learn from you.
You know, if a patient has a pacemaker, for example, already, if he develops pacemaker induced tachycardia, it will be broad.
Right.
Because pacemakers are broad, that's one. The second is if a patient has a accessory pathway conducting antegrade directly to the muscle. So this is called, antegrade tachycardia because WW. So you have, this looks like VT again, but it's a supraventricular tachycardia. Thirdly, if a patient has already a existing bundle block, for example, see normal ECG में left bundle है, तो during supraventricular tachycardia भी वही होगा. Then third, another reason could be sometime that patient has hyperkalemia. It is supraventricular, but because of hyperkalemia, it will be broad.
Broad. Yeah.
So when none of these things is there is something called ablation. What is ablation? Ablation is that there is a functional block of the right bundle or left. Functional. It is not pathological.
Functional.
Functional.
Yeah. So
So there is a lot of electrophysiology involved in this case, but just I want to tell you that ablation means there is no disease of production system, but it is a functional block. Then there is a fast tachycardia, supraventricular. Either the right bundle or the left bundle may be functionally blocked for some time. Usually it's the right bundle, but sometimes it could be left bundle. For example, we get even sometimes broad complex tachycardia, which is supraventricular tachycardia, not a VT, but it is diagnosed from the periphery as a VT.
but this is transient, sir. This is transient.
This is transient, very right. This is transient. And sometimes what happens that during this, your body ECG sometimes narrow, sometimes broad. So this is the functional you should look. It's not a disease. But when it's a aberration, usually you will have a typical right bundle or typical left bundle. For that you have to read those points, so I will not go into
And
it.
sir, what
Complex.
So anyway, this
was
patient,
wandering pacemaker, will it happen?
no, it's a pacemaker induced tachycardia. Pacemaker mediated tachycardia will be broad complex.
Wandering pacemaker.
No, wandering pacemaker is totally different.
Tachycardia.
Wandering pacemaker is totally different. We will talk about that some next time.
Tachycardia.
So anyway, this patient was referred to us actually that he needed a heart pump. He was so bad. So I say we treated him medically for some time, and this is the technique. We took him to the lab, and we confirmed that it's a atrial fibrillation, and then we ablated this patient. We did AF ablation, and you can see the post-ablation, he came to normal rhythm, and believe me that within 2, 3, 4 days, his ejection fraction started improving from 40 to 30, 30 to 35, 30 to 40. So the thing which I want to tell you that if a patient has heart failure, here atrial fibrillation, you have to bring this patient back to normal, either by drugs or by cardioversion or by ablation.
Rhythm control versus rate control.
In heart failure, you need to bring them to normal rhythm if you want to improve their outcome. Because the rhythm control, the rate control doesn't have much in
Absolutely.
heart failure. So this is another patient, middle-aged women, atrial fibrillation. You can see that, and you see that we did ablation in this patient, and she was also having heart failure. She did pretty well. Now there are studies already, that catheter ablation for atrial fibrillation in heart failure. So if your patient is in heart failure and you are not able to maintain the normal rhythm with the amiodarone or with the cardioversion, they need AF ablation, and they do pretty well. And if you see this trial, death from any cause, heart failure, hospitalization, cardiovascular death, all significant if you do ablation. The same thing, death or hospitalization better with ablation, and hospitalization for person in heart failure better after ablation, death from any cause better from ablation. So the conclusion is that the catheter ablation for AF in patients with heart failure was associated with a significantly low rate of composite endpoint of death or any cause or hospitalization for person in heart failure as compared with the medical therapy. So you need to be more aggressive to have a rhythm control in these patients in heart failure. If you are not able to do ablation, bring back to normal rhythm, then we do avinodal ablation, we do their left bundle case. And that also there is data to show that they do much better. Either you do left bundle pacing, which is simple because it is less expensive. But if you are not able to do left bundle pacing, then you have to do CRT in these patients. Those are including criteria which I don't want to tell you. So Kavana trial was the one which I was talking to you. So now these are the recommendations for AF ablation in patients who are symptomatic. They are not being controlled with drug, or patient doesn't want to take drug. Now it is class 1 indication for AF ablation even without heart failure. But patients who have heart failure, there the indication is much more strong that we need to do ablation, which we do on a regular basis in these patients. I think that's all I want to show these cases. Maybe we can have some discussion. Then I will request Avinash to show 1 or 2 cases before we wind up. Avinash, you are ready?
I think he can show the cases before we have a discussion.
Avinash, you come and show some cases, but they don't go through the complexities because you have to think that these are all physicians.
Very rightly said, sir.
Okay, thank you.
Good afternoon, everyone. Good evening. So I'll be showing some interesting cases. There was a recently So Dr. Kler has already shown you some interesting supraventricular cases, that is cases like atrial fibrillation or supraventricular arrhythmias, WPW syndrome, pathways, bypass tracts, and in these cases. So I'm just going to show you 3 cases which we recently showed in Asian Cardiac Arrhythmia Summit in China, where we were called. So me and Dr. Kler, we both went there, and we showed some of our interesting VT ablation cases. So these are very sick patient, ventricular tachycardia in patients with ejection fraction 15 to 20%. Now this particular case was having a very massively dilated LV. So I'll show you how these things are done. So the procedure planning, 80 to 90 BP systolic. This is the BP which was there at the time during sinus rhythm. So we plan to do these cases under general anesthesia. Hemodynamic support is kept standby, and Dr. Dheeraj is our heart failure and mechanical device expert. And these patients are many times done on impellas. Sometimes they are done on ECMO. Sometimes even they are done on IABP. So these things are required because you are mapping ventricular tachycardia. And ventricular tachycardia could be a fatal rhythm or a life-threatening rhythm. So unless we have an alternative cerebral support, so these all devices, circulatory devices like impella or ECMO, they maintain the cerebral perfusion while you are mapping the ventricular tachycardia and updating. So these are the cases which require them. And how do we know if they require them during the procedure? We keep on monitoring their serum lactate. So if the lactate keeps on rising, so baseline lactate is around 1 or less than 1. And if they keep on rising, then that time we know either we need a circulatory support or we need to stop the case. We can't continue with the case. So these things, they do make our ablation more tricky. And as soon as we start pacing the RV, you can see how the BP falls to 60 to 70 millimeters of mercury. Now this is different. So it was decided to perform the substrate mapping in atrial pacing from coronary sinus for better hemodynamics. Rather than, so usually when we do VT ablation, we pace from one side of the ventricle and then map on the other side to elicit more late potentials and the circuits or the fragmented potentials inside the scar. For this patient, we cannot do that. So we just did substrate mapping. This patient kept on getting various types of ventricular tachycardia. So we were able to map around 5 ventricular tachycardias in this patient. And every time a VT used to come, the BP used to drop to 50 to 60. So that is again a life-threatening event. So this is VT morphology 3 with a tachycardia cycle length of 450. There's another VT with BP fell down to 50 to 60. And each time BP falls, you have to shock the patient. Now throughout ablation, patient was shocked at least 7 to 8 times. And this is a planned case. So we have to keep the anesthetist standby. The whole time the anesthetist is there. Patient is under general anesthesia. But still the body cannot take so many shocking and particularly hard when you are ablating inside. So that's why we keep on monitoring the lactate to know that this patient, whatever we are doing, is still being safe. So we keep on mapping, and as you see that the left ventricle is being mapped. All the red area is dead area, those are the scars, and the pink area is the healthy area. So you can see that underside of the heart is where all the scars are and where all the circuits are. And these potentials which are shown, these are the mid-diastolic potentials. Those are there during the ventricular tachycardia, and once you see them, you know that you are in a critical part of the circuit, and once you give the lesions there, the tachycardia circuit terminates and the tachycardia breaks. So we keep on mapping, and here you can see in the red circle, so tachycardia is going on, and during the critical phase of the tachycardia, we see a line of potentials, and these are your mid-diastolic potentials which we search for. So this is a lava, late potential, all these types of EGFs that we track and we ablate these cases. All these red dots that you see, these are the ablation points or the lesions which are given inside the scar. So VT ablation, we are not touching the healthy myocardium. We are just making sure that the dead myocardium or the scarred myocardium remains electrically silent. Problem comes that area is anyways not functioning. the ejection, mechanically it is not functioning, ejection fraction is 25 to 30%. But electrically it is causing a lot of problems. It is causing a lot of ventricular tachycardia from the scar. So what we make sure is, we make sure that the mechanically not functioning area is also electrically silent. That's what we are doing in VT ablation. So all these lesions, the red color lesions, these are all ablation lesions. These are 1 minute lesions of around 50 watts, 40 watts, given for long duration. So it ablates the area of around 1 centimeter cube. And that's the depth of the lesion we want. So art on an average is around 1 centimeter thick, LV. So all the scar area was ablated, and after substrate homogenization, 3 months follow-up, this patient didn't have any VT. Now this is a very interesting case. This patient also 70-year-old male, CAD, last case I'm showing, PVD, old anterior wall MI, and so this patient also had apical thinning and disc kinesia. So whenever you have apical thinning, that means that there is apical aneurysm. So this patient had apical aneurysm, and whenever you have apical aneurysm, lot of times your VT circuits are inside the aneurysm. So what are we going to do for that? So let's see this case. So this, let me just show you the live cases. So this we are mapping inside, if you can see here. So this is a pentaray catheter, you can see 5 splines. So this is like a paint brush. So we go inside the heart and we touch everywhere, and wherever we touch, patient is on a magnetic, patient is lying in a magnetic field. So these catheters are magnetic tip. So when we go inside that magnetic field and touch everywhere inside the heart, we can create a 3-dimensional magnetic map, 3-dimensional electrical map of the heart. So that's how we do the mapping. And again, the red area is the dead area and the pink or purple area is the healthy area. And that's how we create the map. This is a glass shell on this side. So we are creating the map, still the map is being created, and I'll show you the completely created map, and you'll see that almost entire of the left ventricle is red. So this patient had a massive scar. Almost 60% of the left ventricle is scarred. And this is a patient where it's nightmare. And if you see here, all this area, so this is a ventricular tachycardia going on. This is the QRS complex of VT, this is QRS complex of VT. And in between both QRS complex, you see these electrograms. Now these are the critical isthmus signals that we see during the VT, which we call mid-diastolic potentials. And we track it, we track them, and then we ablate inside. We pace from that site and find out if there are critical part or not, but that's beside the point. So this is the area which we have encircled. This is the total scar area, and we make it a point that we ablate everywhere inside. So this is called homogenization. All those VT points were inside, and we ablate from inside. After so much ablation, still the patient was getting so many VTs. And so this is another fast VT mapped from inside, which was again ablated. All these things are done, and after that, so this is 40 watt ablation with this is surround flow catheter, a new catheter. So most of the technology that we use, so we are the largest user of SF catheters in India. We are also largest user of multi-electrode mapping catheters in India. So our center does the most what you call advanced 3D mapping cases overall in India, volume wise also. And this is a standard technique world over. It is a little bit expensive than the conventional 3D mapping, but it's worth its price in gold because it makes your job easy. You don't load the patient with lot of saline. A traditional catheter has to give 30 ml per minute saline. And this is a patient with 15 to 25% ejection fraction. He'll go into failure during the case. So that's why we use these things. And you can see how many lesions we have given inside. And I'll just show you. So now this side was the apex, apical aneurysm. We cannot give lesion inside the aneurysm. So what we do, we ablate all around the aneurysm. So this is called core isolation. So we have electrically isolated the aneurysm by creating a circle all around it. So these are various techniques of ablating these cases. And after this, after doing so much ablation, again this patient had VT in the ICU. So even if you have done a very good job, you might have ablated out of the 10 VTs, you might have ablated 8 VTs or 9 VTs, but still few VTs can come. Luckily this patient was well controlled on propranolol and other sympathetolytic drug, and we were planning for a sympathectomy. So these are the patients who will require sympathectomy in some cases. But you know, these are the best cases that you can, these are the things that at the best you can do for this patient. besides cardiac transplant and LVAD. So this is a AF ablation case. I just wanted to show live how we do it. So this is a live AF ablation going on. You can see that we are creating the lines, which is the pulmonary vein isolation. So these are the pulmonary veins. This is where the AF comes from. We cannot do anything inside the vein. If you do anything inside the vein, it will cause vein stenosis. So the blood will not come from the lung. So what we do, we burn everywhere around the vein. So how do you burn it? So this is a protocol which is world over the current standard, gold standard protocol. It's called close protocol, in which we have to see interlesion distance. You see live it is showing a distance 6 mm, 4 mm. So while ablating, we can see that between two lesions there is not much distance. So we maintain a distance of 3 to 4 mm and we create a line. Now this line doesn't have a gap. So previously you all must have heard AF to ablate hota nahi hai, wo jata nahi hai, 50% success rate. Those are the past. Current technique and current protocol. So if you do it by that, high power short duration with close protocol, with this you get 90% success rate for paroxysmal, 85 to 90% success rate in paroxysmal AF, and in persistent AF you get 65 to 70% success rate, and I'm talking about long-term success rate. And if you, so this I'm talking in case of persistent and long persistent cases. So for single sitting, some of these patients, they do get recurrence because they have large dilated atria. If they do get recurrence, when you do the second procedure, the success rate goes much higher, more than 80-85%. And sir will remember, we have had cases who were not tolerant to any medicine, and where we did ablation twice and sometimes even thrice, and those patients now it's close to 6 to 7 years, they are all maintaining sinus rhythm. And these are the patients who were given hope, who have lost hope that their AF will never be controlled. So for most of the patients, 85 to 90% of the time, their AF will be gone in just one ablation. In certain category of patients, particularly those with dilated left atria more than 5.5 centimeter, they might require second case in around 30 to 40% of the time. But so that's how we tell our patients that it's not a one-point ablation. We are changing the anatomy inside your body. Many times we are successful in one sitting, but sometimes it needs more than one sitting. It's more like radiotherapy or things like that. So I think most patients are now understanding of this, that there are certain limitations with every procedure. So there are limitations with this. You cannot defy nature. So even if you make this line, nature can heal itself, and then there will be a gap in the line. So next time you go and you have to close the gaps. That's why the recurrences are there most of the time. So this is how our live AF ablation case looks like. This is I'm just showing these cases.
Avinash,
I think. Yeah. So this is finished.
Lot of discussion.
Yeah. So I think now if there's any question, sir is there. Answer any questions.
I will just give few comments. See, I understand that for most of you, it's all,
It's an English movie which we hardly understand.
Some movie which is from the star. But let me tell you that last 20 years, 15 years, cardiac electrophysiology has developed so much that we can deal with most of these problems. And in India, actually, to be honest with you, we are late as compared to many countries. If you talk about dedicated electrophysiology centers in India, dedicated, there are not more than 20. Believe me, in North India, Delhi maybe were 2 centers, 3 centers. Punjab, Chandigarh, Haryana, J&K, none. So these are very difficult cases which Avinash was trying to show you. See, simple arrhythmias like narrow compressed tachycardia, AVNRT and AVRT, those were simple. There are many people can do that. But when we come to the complex rhythm problems like atrial fibrillation, particularly in dilated atrium, when we talk about ventricular tachycardia, those are not easy cases. Particularly if there is an organic heart disease, heart is dilated, like ischemic heart disease. I remember one patient, Avinash will remember also, we were at PSR at that time. There was a patient who had an ICD and he was in Sikkim and he had 50 shocks in one day. He had VT, again shock, VT, again shock. So we flew on the air ambulance, and the poor Avinash had to do the ablation in the night from 10. He started 10 p.m. and continued till 2 a.m. And believe me, after 4 years, there was no weekly after that patient. So, lot can be done in that patient, so you don't have to say कि कुछ नहीं हो सकता. These patients, they need a proper center. I can't do alone. If I am alone, I can't do the difficult. It's a team work. You have to have a good lab. We have a very sophisticated three-dimensional mapping system. We have 3 electrophysiologists, then we have an anesthetist, we have a dedicated lab. These patients cannot be done otherwise. But the good thing is that we can do these cases now in India. And don't say any patient that nothing can be done. At least give us a chance to treat those patients. When we talk about heat showed ischemic ventricular tachycardia, dilated hearts, nobody wants to touch them. Believe me, nobody wants to touch them. And the good thing is that we started doing air formation in 2017 on a more regular basis. And ischemic ventricular tachycardia from 17 and 18, it's already 7-8 years. Believe me that even in spite of the patient being so sick, we have not lost a single patient on the table. That's a lucky thing. I think one patient had a pericardial tamponade many years back, and it was a little bit of late detection by the doctor on duty in the night. So he had a cardiac tamponade, cardiac arrest, he died, one patient. After that, we didn't have. One patient had such a bad heart, lactic acidosis, and he developed infection later on, but very rare mortality. That's a good thing. This is a very sick patient to treat. This patient needs a lot of hard work.
So, friends, what a wonderful talk by Dr. Kler, Dr. Avinash as well. So let me start by saying that rotablation, as Dr. Kler said, is a modality of choice here, especially heavily calcified lesions where you cannot do a routine angioplasty. So this is the modality of choice.
You even cannot pass a balloon and get right.
So, Dr. Kler, tell us, what about the perforation rates here?
Well, I think perforation rate are 0.5%.
0.5.
The thing is, the trick is to road ablation is that please don't be in a hurry. Don't force the work. Let it do. Come, go forward, come back, forward. Don't put pressure on that. But what we see, we monitor the revolution per minute. So we set up the revolutions of something like 180,000 revolutions per minute of the work. If it's finding a resistance, the speed will go down. So don't want the speed to go down. Go slowly, then the complications are much less. But yes, he's right that perforation can occur. So you have to be ready for perforation, and the rate is around 0.1. The perforation will particularly occur if there is a bend in the artery. If it's a tortuosity, because the cutting may be only one side. It goes on cutting on one side, then you can have perforation. So in general, if the tortuosity is more than 90%, then one should do either water rotablation or you have to be very experienced.
Sir, for you, perforation rate is 0.5. What is in general?
You are right in that. The thing is, to be honest with you, in India, no true data is available for anybody, including T S Kler. We don't have real good data. But yes, in good centers and people who do rotablation on a regular basis, it's 0.5%, less than 1%. But rotablation is one thing which everybody can't do. You have to have a skill to do the rotablation. That is why what happens that many times you do see angioplasty being done in some centers where the stent is not properly expanded. Now, if there is no expansion of the stent properly, if it's an under-deployed stent, it has more chance of stent thrombosis, more chance of restenosis. Hopefully in some next meeting I'll show you one case. The stent was only 40% expanded, 60% it was not expanded. He came with stent thrombosis and it was a hell of a job to rectify, because if you do the proper bed preparation before stenting, do rotablation or IVL before stent implantation, it is much easier. But if you have deployed the stent, it doesn't expand, then it is much more difficult.
So, Dr. Kler, is there anything which you can't do? So, let me continue. Were you at the HRS April 24? Sorry, 25?
Yeah.
You were there? Yeah. Wonderful. So, some wonderful late breaking trials and data were presented at the. I was not there. I'm always with you, but so he was there. And some late breaking trials were presented. And the biggest ovation was on pulse field ablation.
I'm very impressed by Tulsi da. Tulsi ji. He knows what is pulse field ablation. I'm really surprised and very happy. Now let me tell you, let me make it clear that when we do ablation means to burn. We want to burn tissues, we want to do necrosis of those cells which are responsive for arrhythmia. So now traditionally there were two methodologies. One was the RF ablation, radio frequency thermal. So you heat the tissue to 70-60 degrees Celsius and there will be cell death. The second came by the cryoablation. Cryo means to freeze the tissue to minus temperature and to cause the death of the tissue. Now the latest technology is pulse field ablation. Now it is very different. The mechanism of pulse field ablation is by electroporation. What is electroporation? That usually you have different tissues have different electroporation gradients. For example, atrial tissue is different, cranial nerve is different, the ventricular myocardium is different. So what has happened? For example, in AF ablation, one of the complications is to be cranial nerve pulse. So when you use pulse field ablation, the cranial nerve pulse is almost practically zero because it's a nerve. It has a different electroporation gradient than the muscle tissue. This technology is not yet available in India, but I am trying my hard to get it as soon as possible. With this, atrial fibrillation ablation will become not only less risky, very safe, but you can do the whole case in 1.5 hours time. 1 hour, normally these days we take 3 hours, 3 hours, and we have to do a general anesthesia, but it will cut down the time, it will also make it more safe. But he's right, please listen what is pulse field ablation. It is going to come very soon, so you should be aware of that.
So sir, this seems to be the gold standard today for persistent atrial fibrillation because it saves the phrenic nerve, the esophagus, and the pulmonary veins as well. So this seems to be the future, the gold standard here in persistent atrial fibrillation. Having said that, sir, since you attended the recently concluded Heart Rhythm Society conference at San Diego, just about 6 years back, they also talked about ventricular ablations. At least 3 landmark trials were presented. Talking about the 3 landmark trials on ventricular ablation, sir.
I said very rightly that even now the pulse field ablation is being tried in ventricular tachycardia, but we are in the initial phase of those results. See, 2 things which are the latest invention in electrophysiology. One is the pulse field ablation, which is and actually, to be honest with you, I didn't expect that anybody will know here what is pulse field ablation.
So what is the source of energy in this?
Ultrasound.
This is not ultrasound, this is
high amplitude.
Ultrasound, radio frequency,
High voltage, focused ultrasound.
this is a voltage, they create a voltage gradient between 2 tissues. It causes pores in the cell membrane. It causes multiple pores. So because of pores, the cell membrane, the leaks start leaking and the cell death happens. So anyway, the second which is which you may have heard already from many people is what is called as physiological pacing, the conduction system pacing, which I have not covered. I have not covered But believe me, conduction system pacing is one of the best things which can occur for pacing patients, because you create what nature has created you already. Like for example, we used to put the right ventricular lead into the right ventricular apex or the septum. We used to pace the myocardium, not the conduction system. Now we pace the conduction system. We started with hip bundle pacing, now we have gone into left bundle pacing. We can capture the left bundle specifically, and then the conduction is normal in those patients, and those patients do much better.
It's close to natural.
Absolutely.
More synergy, more physiological, pacing here. So talk us about ventricular arrhythmias, at least ablation. At least 3 landmark trials presented in the recently concluded Heart Rhythm Society conference. Just 6 weeks back, the Avinash 3 trial, also the Brugada, a brave trial, and also the pause SCD, sudden cardiac trial. Sir, talk us about the ventricular ablation in landmark 3 trials, sir.
Well, I will not have specific answer to this question because I have not gone into the depth of this matter. But what the trials have shown that the VT ablation, the cases like Dr. Avinash showed, it is not that they only cause less of shocks, but even there is a mortality benefit in these patients. Because though we put the ICD for giving shock to the patient, but every shock decreases the ejection fraction. So all those patients where they recurrent VT discharges, they should be avoided. I think in the interest of time, maybe.
I'll give it to Dr. Kalra, sir. He has promised to be very kind to us.
I'm always kind, sir. Unlike my other friends, sir. He has anti-gradely stolen my question. I was about to ask pulse field ablation. Anyway, how about renal artery denervation? There are now new changes, new advances.
I think very important question that Dr. Kalra has asked. The renal denervation came with a lot of fanfare, then it disappeared because this Iranian trial didn't prove the benefit. Now the Medtronic has come with a new catheter and it has been shown that it is useful. So you will see this in a resistant hypertension where you have at least 3 trial patients still not controlled. I think one should consider that.
I have one comment.
And it is a simple procedure, it's not a great procedure. You just put the catheter in the renal artery and you give it.
Sir, no question. I have just a comment. Like you said about rota ablation and all that. Is it equivalent to DNC that many people are doing? My question to my friend.
Sir, a related question. Earlier, renal denervation is very old method, but I think it failed because earlier cardiologists were doing very close to renal artery. Nowadays, I heard that it is doing near the branches of the renal artery. It should not be very close to renal artery. Is it?
No, you have to go to the renal artery, but the catheter has multiple pores.
Yeah, but
It's a coiled kind of catheter.
Yes.
It will touch the renal artery. You can have multiple pores.
you should not focus on the main renal
No,
artery.
you go to the branches also.
You are inside the renal artery and you are using radio.
You give it to the main renal artery also in the branches. Previously it was a much less. But a lot of companies are coming with renal denervation. But I must warn you again here that to say that renal artery denervation is the greatest thing is not true.
Case selection.
It's not true. You should use only if the patient has used 3 or more than drugs and the BP is still not good.
Case selection is very
Sir, Dr. Avinash, I just wanted to know a question from you. What about chances of rhabdomyolysis due to repeated shocking as you are doing in a case? Because we are shocking acting on the heart and the whole of the body muscles. Is there any chance?
So rhabdomyolysis is a skeletal muscle injury most of the time, but the myocardial damage does occur. That's why you can detect the troponin increase post defibrillation, and that is why too much defibrillation is not recommended. We don't want it. Unfortunately, in such cases, we need it if we don't want ventricular tachycardia. any DC cardioversion or defibrillation does damage the heart, because you are applying close to 700 volts of electrical gradient throughout the heart to get the defibrillation
Can you
threshold.
prevent that by doing a ventricular ablations?
Yes.
Yes, so that's one of the reasons why we do VT ablation, because we don't want patient to get like recurrent shocks.
It will flutter, and I am in my hometown in Sonipur, and I know that this is flutter, and it will take some time for me to contact you and send the patient to you. What can I do in my setup in Sonipur with the patient?
First is anticoagulate. Don't try thinking of cardioversion immediately, because flutter is taken just as atrial fibrillation. Patient might have a clot. So don't go for defibrillation unless, don't go for cardioversion unless you have checked that patient was having uninterrupted anticoagulation for at least 3 weeks, or you have done PE and found out that there is no clot. So this thing is must. Initially you go for rhythm, you go for the rate control. You give digoxin, you can give beta blocker, you can give even diltiazem, or you can sometimes give any other rate reducing drugs. Usually we don't recommend giving Quadron. The reason not giving Quadron is because it can cardiovert the patient. And if you don't know what is the clot status inside the LA, you don't want to do that. So rate control is
the anticoagulant in what dose?
Eliquis products, I mean Apixaban or Dabigatran or Rivaroxaban or 5 mg twice a day for Eliquis, or for Dabigatran 150 twice a day, and Rivaroxaban 20 once a day.
Right. Now I have a patient and I know that this is documented ventricular tachycardia, and he's been having intermittent ventricular tachycardia. What do I do to the patient? Should I send it immediately to you? Is it an emergency? Is it a red flag? Or I can keep him for overnight in my nursing home and send to you tomorrow morning?
If the ejection fraction is normal, so it's a structurally normal heart VT, then there is no emergency. You can very easily wait in the hospital. You can send him next morning or even take some more time. But if the patient is low ejection fraction, structural heart disease, either ischemic, non-ischemic, sarcoid or any structural heart disease with low ejection fraction and getting recurrent ventricular tachycardias, I will suggest get an ambulance and send him, because these patients can deteriorate at any time, and you know it's difficult because even if you shock them, the VT keeps on coming back. Then you need to do more maneuvers to get rid of them.
For a general practitioner like me, which arrhythmia is more harmful, atrial arrhythmias or ventricular arrhythmias?
Ventricular arrhythmias, definitely.
Ventricular arrhythmias.
So, Dr. Han, one thing I want to tell you everybody, that no, any rhythm problem, any rhythm problem, most important thing is to know that the patient has structural heart disease. If the ejection fraction is good, normal patient marega, which is it. But if the ejection fraction is low, he is the guy who will die. So don't take chance with the low ejection.
Dr. H. Kantru, sir.
Ejection fraction.
There is rotablation, and then there is lithotripsy or calcium removal of the coronary vessels. How does it differ? And is it done with the same sitting, or is it something different? Because in the rotablation we are removing the plate, and naturally the calcium will also go out from it. How is it different from the litho?
The rotablation is more useful than the calcium in the endothelium, in the inside the heart. It will raise the calcium, it will make it fine particle. But if the calcium all round, particularly in the media of the epicardium of the vessel, the rotablation will not do much. Here you need the IVL, which is the ultrasonic wave being bombarded, and then that will break the calcium. So but the thing is in IVL, you should have enough space to go, because this balloon is thick, it's difficult to push. If you can push the balloon to the right place, then IVL is very good. But if you are not able to do that, then you have to use the balloon dilatation or rota before you do it.
One more question, sir. About this pulse field ablation.
Dr. Rajani has a question, sir.
Pulse field ablation, I want to ask you, sir, how does it work, sir? What is the material used? How does it
Already talked here.
cryo ablation and radiofrequency
Basically,
ablation?
pulse field ablation is another way for cell necrosis. is called cell necrosis by causing multiple holes in the membrane and the cell die. This is relatively safe because it's more tissue specific. For example, if you do eye ablation, तो नर्व को भी डैमेज कर सकता है, मसल को भी कर सकता है।
मगर क्या मटेरियल इस्तेमाल करते हैं सर इसमें?
Sir, I can tell, sir. You take multiple electrodes. You take any two electrode, apply 1200 to 1500 voltage per centimeter voltage gradient. So this voltage gradient we can modulate. So the atrial electroporation gradient is around 500 to 600 volts, and a nerve electroporation voltage is around 1500 to 1800 volts. So if you apply a voltage gradient between two electrodes of around 600 volt in a very localized area, the cell which is coming in between those electrodes, they get these small holes outside the membrane. So then that causes the electrolytes to come in and out, and it is without any heat.
सर इतना हम लोग को जानना चाहिए क्या इतना?
नहीं कोई बात नहीं, कोई बात नहीं.
No harm in having
Dr. Rajni has a question.
So very nice talk, but I am in CJS and nowadays I didn't understand the difference between rotablation and the use of IVL. But in most of the cases nowadays we are getting permissions for IVL even with angioplasty and with the TMER. So how do we know whether it is ready? I mean, if a case is presented and the patient has submitted request for reimbursement of this, which is around 1 to 1.5 lakhs, then how do we decide at our level whether we should give permission for IVL usage or we should deny it?
I think the best would be to see the angiogram if you have the capability.
I was put probably determine that.
But if you are not, if you don't have the capability to see the angiogram, then you have to depend on the report of angiogram. If there is a multiple calcified, they have marked calcium here, that means that patient needs something, either rota or AIV. But it is very difficult on your part to determine what patient needs what. So usually what happens that we have to send many times, they ask for CD.
Yes.
You know, there are people, for example, from the government hospital, GP hospital, they will ask for the CD.
We always ask for
Yeah.
CD.
So then after seeing the CD depends.
Okay, and one IVL catheter cannot be used after sterilization for the second patient.
No.
It has to be one.
You know, there are two kinds of IVL catheter available. One is the traditional one, it had 8 times pulses. You can use it 8 pulses in that patient, but now the new one is 12 pulses. But we can't reuse it.
Before you do an IVL, you need to do an IVUS to see the burden.
But rotablation can be reused. IVL cannot be.
Thank you, Dr. Rajni. Dr. Kalra has a question.
Very simple. I don't know whether it is relevant or not. During rota ablation, is there any chance of hemorrhage by the calcium particles? I don't know how small particles.
Right. Very good question. The complication of rotablation are one is called slow flow or low flow. You do rotablation, after that there is no flow in the artery. Because of that muck you have ablated, that goes into the distal capillary and it blocks the capillary, and it's a very deadly complication and very difficult to treat. So the best thing is in these patients is to prevent the low flow. How to prevent? Give them verapamil, adenosine before you start the rotablation. Number 1. Number 2, go very slow. Number 3, depending on the degree of stenosis, go from lower bar. For example, use 1.25 bar, not 1.5 bar. So you need to prevent that. Another is the perforation which we have already discussed.
Thank you.
Any question from the audience? None. Thank you, sir. I think you have clarified all the doubts. I would give it to Dr. Tulsi and Dr. Kalra, sir, to summarize this CME, just carrying home messages for